I'm delighted to have a chance to share some of my thoughts about brain health from the point of view of mechanisms and intervention. A number of years ago, I had the opportunity to give a talk to the Lupus Society of America, along with a well-known rheumatologist at the time. And right in the middle of my talk, where I was discussing cognition and other neurological outcomes from systemic lupus, the chairman of the invitation committee in the middle of my talk said, "Stop." And I said, "Excuse me?" He said, "You got to stop," talking to me from the front row. So I stopped my talk. She walked up to the lectern and she said to me, "You know, you probably thought there were just physicians in the audience, but in fact, there are patients in the back and they're freaking out." Lecture's over. I walked back to the end of the room. I sat down among the patients and I said, "Okay, you have to talk to me. What's going on?" And they were telling me about how upsetting the presentation was. And finally, one woman looked at me and said, "You know, I don't care about the stigmata on my face. I'm not worrying about if I have to lose a kidney." And then she pointed her finger right in my face and said, "But don't you take my mind from me." And that story has stuck for many years. And then in the ensuing time and seeing patients, and so many of them having disorders of cognition, and there was nothing I could do about it, nothing. And even today, how many truly disease-modifying drugs exist? For all intents and purposes, nothing. And so it just struck me that we had to do something in order to prevent the problem in the first place, because once you had it, fundamentally, you bought the farm. And so this work really comes out of that general sense of trying to do something proactively to mitigate a problem that had been plaguing me as a practitioner for many years. So let me just, I don't know why my slide is not advancing. See if I can get this to work. There we go. So I'm going to talk about some definitions so that we have a common ground that we're going to be talking about things, the magnitude of our challenge, what are our brain health targets, when should intervention begin, and then the role of primary care. So I want to bring out the point that we can discuss brain health in many different dimensions. We can talk about it clinically, which would refer to perhaps the absence of cognitive impairment from disease. Pathologically, I think we are addressing the absence of neurodegenerative, cerebrovascular, cancer, or other diseases that interfere with everyday physical, emotional, and cognitive function. And then we can talk about all of this from a pragmatic point of view, that is from the patient's point of view, where we're talking about the preservation of neuronal function to meet the demands of everyday life, which we can operationally define in terms of the capacity to function adaptively in one's environment. So the emphasis here, rather than on disease per se, is on positive biological states. That's what we're trying to promote. So it will come to no surprise to anybody here that our population is aging. And if you look at the graph here on the left and the distribution of ages for males and females in 1960, you can see that at that point, the majority of the population was below the age of 20. And it's projected by 2060 that if you look at the distribution of males and females, you can see the shift to older ages. And it just turned out that millennials, by 1/2 of 1%, just past baby boomers, is the largest individual age demographic that we have now. So we are definitely getting older. So with the aging of the population comes an increased prevalence of neurodegenerative disease, especially Alzheimer's. And so here we look at roughly the current data where it's estimated about 6.1 individuals are estimated to have Alzheimer's disease today. And then by 2060, it's expected to double based on the aging of the population. Not so much the incident, but at least the aging of the population. So it's really interesting if you take a look at the burden of neurologic diseases across the United States from 1990 to 2017 from the Global Burden of Disease Survey. So the graph on the left is looking at stroke with regard to age standardized disability adjusted life years per 100,000 life years for neurologic disorders. And you can see stroke ranks #1 in terms of disability. And you can see the disability from stroke actually has dropped a little bit over the years, but still is the highest among all other neurologic disease. We can skip migraine for a second. And third is Alzheimer's disease and related disorders. So the fact that stroke and Alzheimer's disease rank 2 out of 3 of the top disability causing conditions is not a surprise, and in fact is instructive because it tells us something about the relationship between these two conditions. So if you look at the burden of diseases geographically, on the left you have the burden of stroke, and here you can see what is frequently described as a stroke belt. And it's somewhat embarrassing to see that if you look at life-adjusted years, my new state of Alabama has the worst disability for stroke in the United States. In fact, it has the highest stroke mortality in the United States. But if you look at Alzheimer's disease and dementia, it's roughly in the same place. And so we have Alzheimer's disease, we have stroke, and it begins to make us ask the question, then if this is geographically co-located, what are the relationships between these two conditions? Well, as there is increasing evidence that I think everybody knows here, that there is an interaction, people describe it as an overlap, but I think an interaction between vascular disease and Alzheimer's disease. And there's an increasing amount of evidence to suggest that factors involving atherosclerosis, inflammation, and hypertension, small vessel disease lead to decreased cerebral blood flow. This is a notion that De La Torre posed almost 25 years ago, and he was way ahead of his time in thinking about this. That in turn produces oxidative stress, it produces neurovascular unit breakdown, blood-brain barrier dysfunction, all of which leads to oxidative stress, increased accumulation of A-beta, and Alzheimer's disease. And white matter hyperintensity and brain infarction as an intermediary as we go along this axis. So if we think about upstream, these particular conditions, setting the stage for this cascade over time, the question is, what can we do with regard to these conditions that might mitigate this cascade happening in the first place? So, and one of the things about, I'm trying to move my display here. There we go. So what can the healthcare community do proactively to mitigate or forestall the onset of cognitive decline before it happens? And the proposal is that we emphasize brain health as a part of the goal of preventive interventions across the lifespan, and that the best setting to do this, as I'll describe a little later on, is the primary care setting. So over the last decade or so, the American Heart Association has been active in beginning to take a look at modifiable risk factors that exist across the lifespan, which potentially could be treated in order to improve overall health. And so Life Simple 7 was first proposed by Lloyd Jones and his team back in 2010, and has been put forth into the notion of optimal brain health, and then ultimately how we could put these particular targets into primary care. We're talking about blood pressure control, cessation of smoking, engaging in regular physical activities, reduction of diabetes risk, having a healthy diet, weight control, and control of lipids. And there are others which I'll describe later on, but these were the initial modifiable risk factor targets that were proposed by American Heart that we've been working on. Now, I think it would be naive to say that these particular lifestyles and factors that we're addressing exist independently. They absolutely do not. They all interact with each other, which makes it, on the one hand, difficult to establish the relative importance of any one particular one, even with very complex statistical models, but also in a larger sense says that if we're going to actually achieve brain health, we should be looking at all of them in terms of our overall goals. So people say to me, well, this doesn't sound new. American Heart's been talking about blood pressure control and diabetes for years. Why the new urgency? Why do we need to rebrand this as brain health? And the reason actually is we're not doing such a good job. 87.5 million people in the US still have hypertension. And more than 81 million people are diabetic. I'm talking about type 2 diabetes. 140 million people are obese. And about a sixth of our population continues to smoke. Half of us don't meet the physical guidelines for physical activity guidelines. And in the stroke belt where I am, Afro-American Blacks are 2 to 3 times more likely to suffer stroke and dementia. My state of Alabama now ranks at the bottom quintile of sleep hygiene. And as I mentioned earlier, Alabama has the highest stroke mortality and the 3rd highest AD mortality in the United States. So it's not that we're doing so much wrong, we're not doing enough because of the prevalence of all these conditions. So we are trying to come up with a new agenda, a new way of approaching this, a new system of marketing and messaging to be able to change the behavior of people to reduce these factors. So let's go through a couple of them, some of the underlying mechanisms that are important, because in the intervening years since Lloyd Jones came out with the original 7 that we need to pay attention to, we know a lot more about how these factors influence the onset of cognitive decline and dementia. And there's no question that hypertension is the 800-pound gorilla. And if you look at all the things that hypertension engenders, it upregulates receptors for advanced glycated end products, which increases A beta transport across the blood-brain barrier. In turn, blood-brain barrier disruption from hypertension creates more permeability, less clearance. We accumulate A beta, we get Alzheimer's disease. And hypertension causes small vessel disease, which results in decrease in cerebral blood flow, increase in inflammation, hypoxia, which in turn increases A beta, which is not being cleared. And then finally, of atherosclerosis, which can produce cerebral hemorrhage and infarction, producing vascular dementia. So hypertension has this pleiotropic effect on all these factors, all these mechanisms, which result in cognitive decline. So the data that shows that blood pressure control, or the lack of blood pressure control causing dementia, has been around for a long time. And these are data that were published about 10 years ago. And above here, we have the incidence of vascular dementia versus control. Below, we have the prevalence of vascular dementia, with the right side of these graphs showing increased risk, left side showing reduced risk. And the data are really overwhelming that blood pressure is involved in the onset of cognitive decline and dementia. What are the targets? Well, meta-analysis of 7 studies showed that a systolic of 160 increases AD risk by 25%, and a systolic above 140 increases risk by 18%. And then the Framingham Offspring study showed that if you have a blood pressure of 140 over 90, greater than that, you have a 96% increase in as a hazard ratio for incident dementia. So if you change blood pressure, can you change cognitive decline? It actually allows me to bring up a point here. There's no illusion that by engaging in risk factor control, we're going to make people smarter than they already are. This is really the question of how you maintain function over time. How do you preserve what they have? That is our goal. And so if there's decline because of disease, you could perhaps bring it up to closer to a premorbid level. But there's no sense that, in fact, we're going to make people better than they already are. And there's some studies with exercise, for example, that claim that you can improve cognition. And in fact, there's very little evidence that cognition can be improved beyond its ordinary baseline. So in this study, this is the SPRINT study that was done just a couple of years ago, which was comparing 2 different levels of systolic blood pressure control, 120, the more intensive group, and 140 millimeters of mercury in the standard group. And they looked at cardiovascular endpoints. And as most people know here, the study was actually ended early by the DSMB because the evidence was so overwhelming that a systolic of 120 was so much better in preventing cardiovascular death. So there was an ancillary study to that called Sprint Mind. And so they had as its goal to see whether or not standard treatment or intensive treatment would be better in preservation of cognitive decline. And so they looked at the cumulative incidence of dementia as their primary outcome, and MCI and a combination of MCI and dementia as secondary outcome. And unfortunately, when the trial was stopped early and medication was stopped as well, blood pressure did go up over time. So they were measuring as much of a legacy effect as they were actual changes in function over time. But in their primary outcome for dementia, clearly intensive treatment had a lower cumulative incidence of dementia than standard treatment, although it didn't quite meet statistical significance with a p-value of 0.10. But there was a clinically significant diminished onset of mild cognitive impairment and a much lower incidence of composite of mild cognitive impairment and probable dementia. So control of blood pressure can mitigate cognitive decline as long as people maintain their target blood pressure. What about diabetes? Diabetes also has this omnibus impact on cognition in regards to its production of hyperglycemia and insulin resistance and dyslipidemia, resulting in inflammation, production of oxygen species, and glycosylation and accumulation of A beta, resulting in, again, breakdown of the blood-brain barrier, neuronal degeneration and apoptosis, and synaptic dysfunction, including degradation of long-term potentiation and MDNA receptor dysfunction. All of results in cognitive impairment. So in a study that was done by Blom and colleagues, they looked with 7T MRI at hippocampal subfields among those with diabetes and normal controls, and also looked at those with hypertension. If we look here on the left, and you can see this is for diabetes, the y-axis, the Z-transformed volumes, where increased volumes would be above the level here, and decreased blood volume, brain volumes would be below here. And these are the different hippocampal subfields, gray being the patients with diabetes, black being the control, and you can see diabetes results in a clear loss of brain volume. CA1, CA2, with CA1 obviously is critical for memory, the subiculum entorhinal cortex. Interestingly, hypertension does not affect the hippocampus in quite the same way. So there seems to be a disease-specific effect on the structure of the brain that's so critical for memory. But this is a physiologic and neuroanatomic demonstration that diabetes does cause important degeneration within the brain. Diabetes also has an interaction with aging and obesity, resulting in increased insulin resistance, decreased secretion of insulin. And I won't go through all of these, but obesity and aging do all the things that impact those things which will overall produce type 2 diabetes and result in cognitive decline. And you should notice that here with malnutrition, physical activity, this again shows you the interaction between these factors that diabetes and exercise and diet all interact with each other. So the Rotterdam study showed some years ago that if you look at dementia subtype, those with Alzheimer's disease with cerebrovascular disease had a relative risk of 3.0, and just the presence of vascular risk factors alone, vascular dementia has an increase of twice the population as a whole. So the diabetes definitely increases the likelihood of dementia. So can we do anything about it? Well, in a recent study that Tali Kukerman-Yaffe published in Lancet Neurology with her colleagues, looking at the effect of dulaglutide on cognitive impairment in the REWIND study. So the REWIND study was a double-blinded, placebo-controlled study involving 371 sites across 24 countries, with 4,500 on drug and about 4,400 on placebo. The cognitive outcome was the MoCA score, which is the 30-item score on a screener, and the digit symbol substitution test, which I'll describe in a second, with the incidence of cognitive decline defined as 1.5 standard deviations or greater over time. And when you adjust for baseline factors such as age and ethnic origin and education and sex, as well as controlling for death, to the left favors dulaglutide, to the right favors placebo, and you can see dulaglutide definitely decreased the incidence of cognitive decline during the study period. So this leads me into a little of a tangent, little segue about why are we studying cognition? I mean, everyone knows about its importance to us personally, but diabetes in the brain. I mean, when I was doing my fellowship at Sloan Kettering, Jerry Posen said to me, well, you know, cognition, that's the soft stuff. And I would like to convince you that is not the case. In a study that I did in diabetes a number of years ago with Tally, and it was a piggyback to the Accord study, which was looking at intensive versus standard treatment of diabetes that was also stopped early, unfortunately, because of adverse events. But we had a sub-study of almost 3,000 individuals where we looked fundamentally at memory in those over the age of 55. And we wanted to see the impact of two different levels of diabetes control on brain structure and function. And the question I asked in the study when we put this together is, does cognition predict major adverse cardiovascular events, including non-fatal stroke, MI, and cardiovascular death 4 years later? So what we did was we took the Accord cohort at baseline. We gave them the digit symbol substitution test, which I'll describe here. This is really a simple cognitive measure where individuals are presented a little key at the top of the page, numbers 1 to 9, with a corresponding symbol under each one of them. And they simply have to fill in the symbols according to the number as quickly as they can until we tell them to stop. And the duration now is 120 seconds. So this is just a simple cognitive test. And so what we did was we gave this test to our 3,000 patient cohort. We divided them into quartiles within the normal range at baseline. And so that you had the highest quartile and the lowest quartile, or better than those who might have had some degree of impairment, and asked, does this breakdown in quartiles predict cardiovascular outcomes? And so we published a couple of years ago the paper on looking at log rank incomes of the proportion of event-free change over time. And I keep on having to change my location of my gallery here. I'm going to put it down here. And so each curve represents those initial quintiles in the normal range. And so the solid line represents those who are in the highest quartile at baseline. The large dotted lines are those who are in the second best quartile. The sort of smaller dotted lines are those who are in the third quartile, and the dashed lines are those who are in the lowest quartile. All these, again, were in the normal range, and we look at the data 4 years later, and you can see how well that predicted cardiovascular outcomes. And the point is that cognition, beyond its impact on our quality of life, is also an exquisitely sensitive metric of brain integrity. And that's the way we're viewing brain health here. Yes, we're interested in cognition, but it tells us something about the health of the brain. So let's go on to physical activity. If there's any one particular dimension of Life Simple 7 that seems to have the most pleiotropic effect, it is physical activity. It's absolutely amazing. Here we have the 6 other elements of Life Simple 7. You can talk about diabetes. Physical activity lowers LDL and triglycerides, improves glucose homeostasis, improves insulin resistance, increases mitochondrial biogenesis, and reduces inflammation. Cholesterol has the same effect on those factors. Insulin also has impact on all these factors. Diet has an effect on all these factors. Smoking cessation I have here contributes to smoking cessation, and that doesn't quite make sense, and I have to figure out why the error there. But smoking cessation also produces atherosclerotic risk, and so physical activity impacts there. And in terms of blood pressure, exercise increases growth factors, increases angiogenesis and capillarization, and reduces blood pressure. So physical activity has these amazing effects, and that's one of the reasons why we promote it so strongly. In terms of some of the mechanistic reasons why this may be the case, Slyman and colleagues published an animal model back in 2016 in eLife, where they looked at mice undergoing exercise versus no exercise over a 30-day period using a running wheel. And at the end of 30 days, the animals were sacrificed and brain tissue was harvested. And they were specifically interested in brain-derived neurotrophic factor through the action of the ketone body beta hydroxybutyrate. And if you take a look at control versus exercise, you can see that if you look at the promoters of BDNF, control, we see no difference in those who did not undergo exercise, the animals. But if you did undergo exercise, you can see how exercise improved the BDNF promoters. When they do the Western blots, you can take a look at BDNF under controls, BDNF under exercise. And if you take a look at BDNF protein quantification within the brain itself, you could see that the change in the controls was marginal compared to the huge change in exercise. So BDNF seems to be an important outcome of exercise beyond some of the other CBS effects that we have read about in the literature. In the Rush group up in Chicago, they looked at 454 decedents in their Alzheimer's cohort. And they defined, well, they used 19 different tests rather to measure cognition and 10 measures of motor abilities. And they looked at physical activity over a 24-hour period over 10 days. And they looked at fundamentally at how these daily activities, this physical activity was associated with cognition. And it turns out if you look at the correlations between AD pathology, the more exercise you get, the less AD pathology you have. The more exercise you get, of course, the more motor abilities you're going to have, and the more physical activities you're going to have. If you look at the correlation with exercise and beta amyloid, again, a negative correlation. The more you exercise, the less the amyloid. And if you take a look at tau, the more you exercise, the less tau you have. In a French study looking at the benefits of physical exercise training cognition and the quality of life in frail older adults, there were 83 individuals between 61 and 89 years of age, and they underwent 12 weeks of 1 hour per day of exercise, 3 days per week, stretching, balancing, aerobic, strength training, and it was a pre and post experimental design of looking at Z-score change in a variety of dimensions. And if we just look at the cognition data above in the control group versus the physical training group, in every single domain, whether it's a screening test for cognition using the middle mental state or working memory or episodic memory, processing speed, executive function, verbal reasoning, in every case, the physical training group benefited compared to those who did not engage in physical activity. So we're doing some new research in exercise at UAB, and we just received funding from the McKnight Brain Research Foundation, in which we are going to take a look at age-related cognitive decline with exercise in hypertensive older adults to investigate a retinal microvascular biomarker in the role of insulin growth factor 1. And so our premise is that insulin-like growth factor 1, IGF-1, decreases as we get older. There's loss of microvascular density or rarefaction that is related to the decline of IGF-1. That increase in microvascular rarefaction is related to the increase in hypertension, and exercise appears to increase IGF-1. So our hypothesis is that an exercise intervention will increase IGF-1 in hypertensive, which will result in a decrease in hypertension and improve cognition because of vascular density that will be increasing. Well, the question is how are we going to measure vascular density? And so what we are doing is we're using optical coherence tomographic angiography. We're looking in the back of the eye to take a look at vascular density. And so we're going to be using OCTA and looking at the density of blood vessels in the back of the eye before and after an exercise regimen with a washout period control, and to see if we can answer the question, does hypertension go down with exercise as a result of increase in IGF-1 and moderated by the increase in microvascular density? We would love to take a look at CBF behind the eye, but in fact, OCTA yet does not have the technology to do that. But that's a study we're just beginning, and we'll keep you apprised of the outcome. So as I mentioned before, there's Life Simple 7, but there is also other factors impacting brain health. Include alcohol consumption, sleep, social engagement, hearing loss, and mood as a measure of depression. All these things are addressable. That's the point here. So let's take a look at sleep for a second. Sleep disturbance is known to be correlated with increased beta amyloid deposition. It reduces lymphatic clearance, which is a very interesting system to study, something we're interested in. It results in low-grade inflammation, increased presence of tau, hypoxia associated generally with obstructive sleep apnea, as well as the presence of cardiovascular disease, including hypertension, atrial fibrillation, and endothelial dysfunction. So in the Swedish national study of aging and care, they took a look at sleep disturbances and dementia risk. And we just look at the graph on the left. And we have follow-up time over the x-axis, the number of neuropsychiatric disease along the y-axis, and no disturbances in the lighter color and moderate to severe sleep disturbance in the dark color. You can see that over time, the number of sleep disturbances increases as a function of sleep severity. Abnormality, and you can see by the time we get to 9 years, you have far more incidents of neuropsychiatric disease than you do in controls. So what's the optimal sleep duration? Well, in the Hitsuyama study in Japan, they took a look at optimal sleep duration in all-cause dementia, Alzheimer's disease, vascular dementia, and then all-cause death. And as you might expect, there's a U-shaped function in almost every single condition, although less so in vascular dementia. But in essence, about 7 to 7.5 hours of sleep per day seems to be optimal in mitigating cognitive decline to this extent that sleep duration has an impact on that outcome. And then in the Whitehall 2 study that was published this year, you could take a look at also at similar hazard ratios for objective measure of sleep duration and hazard ratio of dementia. And there is also that U-shaped function in terms of the main effect. But if you take a look at the confidence intervals, the optimal sleep duration is somewhere above 7 hours per day to mitigate cognitive decline. So in a state like Alabama, where we're in the lowest quintile of sleep hygiene, this could be one of the major contributing factors in addition to other typical cardiovascular indices such as high blood pressure. And then recently this year, in the RUSH project, they took a look at activity levels before the onset of dementia. And these were functionally 80 years old, looking at survey of cognitive activity and with about 6.5 years of follow-up. And what they find is that with regard to engagement of physical activity, the higher the activity, the later the onset of neurodegenerative disease. Now, one of the other interesting findings in the Wilson study is they took a look at the correlation between neuropathology in these patients who had died and in cognition. And interestingly enough, here we have the no AD controls. Here we have those with dementia. And these are the p-values for the correlations. And they found very little correlation between the presence of neuropathology and level of cognitive function, which I thought was really interesting. And so the question is, especially in the dementia cases, why is it that some patients with a diagnosis of Alzheimer's disease didn't necessarily show neuropathological findings? And so I think one clue comes out of the work of Jeremy Herskowitz's group here at UAB, where he looked post-mortem in 3 different populations of individuals, looking at Brodmann's area 46, which is the dorsolateral prefrontal cortex, layers 2 and 3 of the pyramidal dendrites. He had controls. He had those with Alzheimer's disease with no dementia, and then he had those with Alzheimer's disease with dementia. And if you take a look at each one of these, so here you have the dendrites, and here you have the dendritic spines. And you see controls, you have normal spine presence morphologically. Those with Alzheimer's disease but no dementia also had normal spines. But if you looked at Alzheimer's disease with dementia, you could see the degradation of the presence of spines. So the question is, what is it that we need to engage in? How do we promote or maintain the presence of these spines in order to maintain function as we age? So then it leads us to the logical question, when should intervention begin? And I'm just going to give you 3 studies to give you a frame of reference. In the Cardia study, which has looked at Black and white adults enrolled at the ages of 18 to 30 years of age, and I want you to keep the 18 years old in mind, they found that blood glucose variability below the threshold for diabetes 25 years later was associated with worse memory, processing speed, and language fluency in midlife. 18 years old, 20 years old, midlife outcome. The Insight 46 study has been conducted in Great Britain in a community, all of whose residents were born in 1946. And in a paper published just before the COVID shutdown, in Lancet Neurology, they found that higher systolic blood pressure and change in diastolic blood pressure in the period 36 to 43 years of age was associated with smaller hippocampal volumes and greater white matter hyperintensive volumes at 70 years of age. And so the fact is that this sort of adulthood changes in blood pressure, whether it's variability or just absolute higher blood pressure on the diastolic level, produces these different physiologic changes at 70 years of age. And in the ARIC study, who enrolled Black and white participants between the ages of 40 and 65 years of age, they showed that midlife hypertension, diabetes, poor dietary patterns were associated with increased later life dementia. And just to illustrate this further, this is one of the papers that was published in 2019, where we have time along the x-axis. We have cumulative dementia along the y-axis. And each curve here represents a different combination of midlife and late life hypertension and hypotension. So if you look at the bottom curve here, the black curve, normal blood pressure at midlife and normal blood pressure in later life has the lowest incidence of cognitive decline. Conversely, hypertension in midlife, even in the setting of hypotension in later life, leads to the greater incidence of cognitive decline. So what we do in midlife definitely impacts what happens in late life. And so that emphasizes the point that what we do over a lifespan impacts what happens in later life. And cognition is one of those outcomes where the early life and midlife control definitely has an impact when it happens over the age of 65. So Walter Kernan sitting in the audience, he knows much more about primary care in his fingernail than I will ever know in my lifetime. Knows this fairly well and wrote actually this most significant portion of our recent brain health paper. Standard prevention guidelines of primary care address all the elements of Life Simple 7. And these guidelines come from American Heart, the American College of Cardiology, and the US Preventative Services Task Force. But screening recommendations for paying attention to these factors in terms of its later life implications really doesn't happen much more than once or even per year or even 5 times per year. Now, the continuity in the clinician-patient relationship, exists within the 3 pillars of primary care: evaluation and management of acute symptoms, prevention of acute and chronic disease, and management of chronic disease. And so the promotion of health, including brain health, is deeply embedded in this framework. So we would think that primary care has picked up the ball in this regard. But in fact, the conversation about risk factors and dementia is not taking place. Mouse and his colleagues up in Michigan published a paper in JAMA Neurology 2 years ago, and they looked at a little over 1,000 responses on a survey between the ages of 50 and 64. And they found in this survey that only 5.2% had ever discussed dementia with their primary care physician. Afro-American Blacks perceived their risk as lower rather than higher. And respondents were engaging in strategies that were not evidence-based. And we know of all the things that we see in media that are promoting all kinds of supplements for which there is absolutely no evidence. And that while managing risk factors could reduce dementia risk, few discussions on this matter was actually taking place. So we have an opportunity here. And recent data suggests that in the context of primary care, there should be a broad-based approach. And probably the best evidence for that is the Finker study that was done in Finland, which was a multi-domain intervention among older at-risk individuals in the community around 69 years of age. And it was a randomized controlled trial in which the intervention group received or was required to go through a regimen of diet, exercise, cognitive training, and vascular risk monitoring, whereas control individuals only got general medical advice. So the question is information enough, or do they actually have to do something? And the outcome was change in cognition over 2 years. And so these are 4 domains of outcomes looking over the 24-month period, looking at Z-scores over time. And if you take a look at the total cognitive battery, there was a statistically significant impact for the intervention group. There was a significant impact in executive function and in processing speed, but not as much in memory. But the point is there still was overall an impact in cognition by engaging in this multidimensional program. So what can we draw from some of these data? Cardiovascular risk factors and lifestyle management benefits the brain. There is no question about that. And studies show that these factors are in fact treatable. Treatment appears to lead to primary prevention of cognitive decline and dementia, and that attention to these factors is a lifelong process. And so with that said, I'd be glad to answer any questions that you might have. Thank you for your time.
Wow. Thank you, Ron. That was inspirational, and I think it's only appropriate that you, the least nihilistic among all of us, should be here to tackle some of the initial questions, which really do relate to an understandable sense of a little bit of hopelessness around getting folks to change their habits. We had one question around, if we can't get people to take the COVID vaccine, how are we going to get people to take antihypertensives? And then another question around, what do you think has to happen? How might, what changes, if any, have to happen in the structure in which primary care is administered in this country to make all this feasible? So maybe you could tackle those 2 issues together. That's not too much.
So let's take the first issue. I think that with regard to the first, if you take a look at the vaccine hesitancy in this country and the unwillingness to do something that's prevent, I think that we are not listening to the way people think about healthcare. And that's especially true here in the South with the Tuskegee experience happening only 2 hours from where I live. And so I think the first thing we have to do is learn how to listen to our patients and find out what their concerns, their worries are, what their knowledge base is, without us having any real judgment as we go through the listening process. And that takes time and that takes patience. And in the setting of a pandemic, of course, that sounds sort of counterintuitive because time is so crucial. But the fact of the matter is, if you just take that to brain health, which has urgency, but not the same immediacy, if you will, I think we need to go in and to learn more about the communities in which we want to make a change in. And people will tell you after a discussion, and I can tell you in talking to my patients, I didn't know that. And it's because their sources of information maybe are different from ours. But you have to find out what they believe before we can get them to change their behavior. So I think it's a messaging, public relations, marketing issue as much as anything else. With regard to primary care, I would have to be a primary care physician to answer that question. So I'm going to punt that to Walter and see what he thinks about that.
Walter, that's an ironic punt. Anything you want to add?
I said in my comment line that I think there are two challenges to improving our interface with patients on brain health. One is getting them access to primary care. And two is improving the quality of the transaction between patient and physician in primary care to improve overall quality of care. I want to say, thirdly, I think there are enormous public health approaches to this problem, but I'm going to leave those aside for a moment. Big issue here is access to primary care. Our country has not yet embraced universal health care, and many states still have not even agreed to expand Medicaid under funding from the federal government. So we have those of us who are working in primary care to engage patients in brain health are working against a national trend in terms of how insurance is provided. We can't talk to patients who can't come see us. And those patients, many of them who are coming to see us, face financial barriers to good health. So I wonder, I think in our agenda to improve brain health, we all somehow need to recognize our role as policy advocates.
I would agree with all of that. Absolutely. So with regard to the interface between patients and primary care, what we're trying to do down here in Birmingham, and of course, John and Jonathan and Walter know about this, and Edith as well, is that we are trying to have a clinic within a clinic. And so we are putting a brain health advocate into a primary health care clinic where they're going to have the opportunity to talk to patients and discuss options in terms of achieving these different risk factor lifestyle changes. Because the primary care physician is just swamped with things they have to do. And patients have all these questionnaires and things they have to fill out before their interaction. And so we plan to see them afterwards. And part of this process is going to be talking to patients one-on-one to see how they think about it and begin to think about the motivators that may be able to be effective enough in changing their behavior. Then ultimately, after we do this over time, then we can take a look at scalability. And of course, we're going to use the brain care score as our outcome, because that will give us a metric that both us and patients can easily communicate about in terms of how well they're achieving these outcomes.
So just to be clear, when we invited Dr. Lazar, we said you had to bring some famous friends. And so I'm delighted to just alert everyone that Walter Kernan is professor of medicine at Yale and long been studying these topics as well. We're delighted that he came and joined us as well. Another question that in the chat is around therapeutic potential for IGF-1 from Dr. Rand, who knows lots about this, and any concerns you might have for its role in malignancies.
That's a good question, and we have been thinking about it. We are not trying to, if you will, in humans, inject IGF-1 to get an outcome. We're trying to produce it naturally. And so if you have a depletion of IGF-1, our notion is that exercise will improve it in a therapeutically appropriate way. And we don't think that there's necessarily going to be a risk for neoplastic disease as a result of that, since we're not trying to produce this beyond normal levels. But it's a question, and we're going to have to pay attention to that. And it may be that IGF levels will begin to tell us about how much exercise is appropriate. American Heart says, well, 150 minutes per week of moderate exercise will do that. Well, how do they really know that? And there are some studies to show that. But if we could show physiologically that a certain level of IGF is just right, if you will, to get brain health to be maximized, then maybe that is our target rather than simply a number of hours per week.
I think it would be great if we had that biomarker, as you said, to tell a patient you're doing enough exercise for your risk profile. I think that would be a great advancement.
Yeah, and I think that's one of the things about the brain care score, if you will. And John, I'm not trying to promote it, but I'm trying to promote it, is that all this should be individualized, and that people are going to have wildly different profiles and ability to take advantage of different kinds of intervention, and we have to tailor it. So we cannot use population-based targets necessarily for everybody. We're going to have to think about it in different ways. And some patients will have normal blood pressure, and people will have normal cholesterol levels, yet will have problems. So we're going to have to address them in a slightly different way, perhaps, than those who have hypertension. So your point is well taken.
So a question from Greg Friccione from the Benson Henry Institute for Mind Body Medicine is, one of the topics that we talk about a lot at the McCance Center is, how to assess the level of psychosocial stress. And particularly his question is, how does it fit? How might you fit psychosocial stress into the AD risk model?
That's a really good question. And I can tell you, working down here, the amount of stress that exists in impoverished communities is just staggering. I'm not saying it doesn't happen elsewhere, but it's absolutely apparent. And so looking at allostatic load, for example, as a factor in looking at the production of inflammation, there is a psychiatrist at UAB who's looking at childhood trauma, for example, and levels of inflammation. So it's a very complex question, and it gets to what I think Walter was pointing out in terms of public policy. We can manipulate, I think, these 13 factors we've talked about before, but at a more macroscopic level, looking at poverty and inadequate access to primary care and inadequate educational opportunities, a lack of public transportation to be able to get to jobs, and therefore putting stress on how do you manage making enough money to make ends meet. All those things together are systemic things that we have to address that are at a public policy level. So there's some things that we can try to control, but other things that I think are more macroscopic, and it's going to take public policy changes.
Can you talk a little bit about relative or absolute hypotension and how that might have an interplay with the role of hypertension and risk of cognitive decline?
So that's a good question. And some of the recent studies that I recall, I can't tell you one specifically, are suggesting that hypotension isn't the factor that people thought it was in terms of global hypertension. We know that from work that we've done that carotid stenosis can impair cognition. But in terms of systemic hypotension, there seems to be less evidence than one would expect at older age that there's a necessity to increase blood pressure because of arterial stiffening that takes place over time. So hypotension doesn't seem to have the same impact as hypertension. They're not symmetrical processes with respect to the outcome of cognition.
And then we have another question about if this is an issue of talking to people and primary care access, how come we continue to see all of these disorders even in Scandinavian countries where all of the above supposedly is embedded in their healthcare systems?
I don't have a good answer to that, frankly. But what I wonder is if you go beyond Life Simple 7 and you take a look at stressors. So for example, the suicide rate in Sweden is among the highest in the world, okay? And so there are other factors besides these obvious biological ones that are having an impact, but how I could put that into a cogent answer to the question, I really don't know how to give it. Maybe someone else has a thought.
I mean, I think one thing is that it's not, the content of primary care visits is not as, I think, idealized as we would like it to be, even in countries that have a very substantial commitment to primary care.
Well,
But,
the finger study was done in Finland, and they got this positive impact.
Well, thank you, Ron. That was a fabulous talk, inspirational, I would say, and drew a lot of folks from across the institution and beyond. So we're thrilled about that. And we look forward to the continuing working together. We're thrilled to have the McKnight Brain Center be a partner in this quest with the McCance Center. So thank you for coming.
Thank you for the opportunity to share my thoughts. And you and I are going to stay on for a minute.
Yeah.
Nice seeing everybody.
Thank you, everyone. See you on October 4th for Dr. Randy Golub and Dr. Senya Kastanenka. Have a good day. Have a good rest of your day.